before we get into everything, we would like to thank our sponsors for this evening. We have, oh, I have to put my glasses, sorry. Southern Alchemy Wellness for the space, so this beautiful space that we are in right now. They are graciously letting us having the workshop webinar here, so we want to say thank you. Public Supermarket for the snacks. Automated System Consulting for audiovisual, and Deborah Etienne for the Haitian Creole interpretation. Initiative LLC, but that's for the speaker, which is Genevieve Ovincy. So I begin by letting you know what we are all about at Origin. Origin Foundation's mission aims to increase the level of education and participation of BIPOC communities in positive behaviors to fight different layers of disparities affecting those communities. Our core values are authenticity, being true to ourselves in our originality. Preservation, to give honor to knowledge that has been transmitted through generations and conserving the important aspect that defines culture. Respect, we keep in high regards each other's contribution to our joint journey, recognizing individuals' importance and value. Integrity, honesty mirrored through a moral compass that upholds our action. And sharing, to occupy a collective space of love to promote exchange and growth. Today, we have the honor of being educated by no other than Genevieve Ovincy, leading this important gathering and information session, dispelling the myth about hospice, embracing palliative care, and expanding perspective. Genevieve Ovincy shines as a beacon of compassion within the healthcare range. Within 2.5 years of invaluable experience as a hospice and palliative care nurse practitioner, she brings a wealth of expertise and empathy to her practice. Genevieve's journey, which has been her transition from a dedicated CNA to a seasoned ICU nurse with over 5 years of experience, has bestowed upon her a profound understanding of patient care that is truly exceptional. Throughout the tapestry of her career, Genevieve has not only mastered the technical aspect of healthcare, but has also discovered a fervent passion for patient education and advocacy, and that is why she's presenting today. This passion ignited the creation of Caring Initiative LLC, a visionary venture dedicated to supporting solo practicing primary care providers in navigating the intricate landscape of healthcare. With a specific focus on reducing hospital readmission rates, Genevieve endeavors reflects her commitment to improve patient outcomes and fostering a more seamless healthcare experience. Driven by empathy and a steadfast dedication to holistic patient well-being, Genevieve thrives to leave a lasting impact on the healthcare landscape. Her unwavering commitment to compassionate care and innovative solutions underscore her position as a true leader in her field. So let's welcome Genevieve for today's presentation.
Thank you so much, everybody. That was amazing. Hi, everyone. I'm like Natasha said, I'm Genevieve. I'm so happy to be here, to be able to talk to everybody and giving you a better understanding as to what hospice and palliative care is. So with that being said, we can go on and start with our next PowerPoint slide, please. Okay, so Natasha did such a good job presenting me, so I have a slide that says who I am, but she pretty much summed it all up. But essentially, I went to University of South Florida. I did my a bachelor's degree there. I did a master's degree there, and then I got my second master's degree at Texas Women University while I was in Dallas, living with my husband and our kids. And so from there, that picture, I decided to show that picture because I felt like this was right in the midst of COVID. And so in the ICU, completely gowned up, and that's pretty much what my 12-hour shifts was. I was always covered like this most time, trying to take care of our patients, and that essentially kind of opened my eyes to what health, like I've been in healthcare, but it gave me a different perspective. Being at the bedside as an ICU nurse during COVID was it was sad. Seeing patients day in and day out. Usually we're so used to being able to, if somebody comes in for a certain problem, we know exactly what to do, what to give, and help them make them feel better. But through COVID, it wasn't. It was a hard pill to swallow for us as providers and nurses. And so when we really couldn't help anybody at the time. So with that, I went back to school and ended up being going to get my nurse practitioner's license. And then I thought I was going to go back to the vets to go to the ICU again. But then I'm a very big believer, and I feel like God had already orchestrated my steps, and he actually just placed me exactly where I have found my passion, which was hospice and palliative care. So, but yeah, and so that's really a gist about me. So I'm so glad to have been here, and I love to be able to educate people. So yeah, next slide, please. Okay, so whenever we talk about hospice and palliative care, I think in order to better understand what's going on, what we're going to talk about today, we have to start off by defining everything. So we have to get a better understanding, you define what hospice is. So hospice, oftentimes, you think is where people end up going to pass away, but unfortunately, it's more to that than just passing away. It's really about providing a holistic care for our patients and family members, because it's not just the journey of the patient, it's also the caregivers that have to care for them and be at their bedside and be with them through that difficult time. It's a team-centered. We do have grief and bereavement counselors. You get a lot more support when you are in hospice. You get different resources that you would not really have had access to if you didn't elect to have that service. And oftentimes people don't know that. Palliative care, in essence, it really starts at the beginning of diagnosis. So if you were given a diagnosis of heart failure or chronic kidney disease that now requires to be on dialysis, or the most popular one is really cancer. So you don't have to get rid of primary care doctors and all that to have palliative care. It essentially is a pain management kind of resource or an ancillary service that you can have along with all your other teams of providers. So, all right, and I'm ready for the next slide. Thank you. All right, so now that we're talking, you have a better understanding as to what hospice and palliative care is, the differences. So essentially, they do both reflect somewhat on what the end of life will be. And so it's really important, the end of life care is important to kind of know what does that look like to you and to anybody, to your patients or your family. So two of the major things for me is really understanding the dignity and respect of the, this is, I don't think you have the right slide though. But it's okay. Well, we can move forward. At the end, it won't be the right. So dignity and respect. So individual research, individual deserve the approach of end of life with dignity. So essentially what that is saying is that, do you want at the end of your life to be in a hospital bed and being prodded and poked and all that, having tubes and all kinds of lines, and having other people caring for you, bathing you, or changing you in different ways that are not necessarily respectful, and not just respectful, but not of your respectful to you. And so, because essentially when you are in the hospital setting, our main point and purpose is really to just cure you, get you feeling better. And oftentimes there's different groups of people that come in and out, and you don't get that peace that you necessarily are looking for when you are going to pass. And we're just about looking to provide that dignity and respect that we want at the end of life, as most people would want. And that looks different to everyone. And it could be different for Tasha, it looks different for me, different for you. So, it's just a matter of going through what that looks like for you and determining how do you want the end of life to be for you. And it's important to think about that, because unfortunately we're only really guaranteed one thing in life, is that eventually we'll pass away, right? And so how does that look for you? As you just have to be able to have that conversation, so that it's not something that you do, that it happens, that is not that's something that's happened against your will, okay, or your wishes. So, and the other thing is relief of suffering. And so end of life care focuses on alleviating suffering, really. And it's not just about the physical, it's also about the emotional, the psychological aspect of it, the spiritual aspect of it. Because some people want, I've had patients in the hospital tell me, whenever it happens, please open a window for me. Just so that in their perspective is that, in their spiritual guidance, is that they want their soul or their spirit to be able to leave and not remain. So there's different aspects of that for everyone. And are you gonna have that team that's gonna be able to honor those wishes for you? So, there's a psychological distress that happens, the anxiety and the depression of being maybe lonely, because I circled back to being at COVID at the bedside, because what ended up happening to me is that I've had a lot of patients that would end up passing and their family members could not be there with them. And I was the last person to hold their hands. And I did not know this person from anywhere. They happened to come into our hospital, and I ended up caring for them and barely really knew who they were. But I did my best to be able to at least be there and hold their hands while they were. So that is you want to figure out what is the best, what does that look like to you? When you are going to, you're suffering, what would make you happier? Whether it be having all your family members around you and having, less pain, or just listening to music. If you want your certain music to be played, to respect those, or some people want to just pass away in their home. Some people want to pass away at the beach or something, and so unfortunately in Florida, there's not a hospice house where people can just go and really pass away. But, there's hospice companies all over through all the counties. And so you can always do your research and find out exactly where you want that to happen. So thank you. All right, next one. So we'll talk about our goals of care. So if you don't get anything out of this presentation today, I want you to be able to go out there. If you are going to the hospital, going to your doctor's office, know that there is something we call the goals of care and the plans of care whenever you go to your providers, okay? And you should be able to share that with them, and so that they can be able to respect it. So by you understanding that there is such a thing that happens that we as providers have to essentially address, then you are able to make better informed decisions and be able to tell them, speak eloquently enough to tell your providers, hey, here's what my physical comfort I'm okay with. So let's just say we usually would have a pain scale of 0 to 10, right? And so, they'll ask you all the time, so what is your pain level? What is your pain level today? What was it yesterday? What was the day before, And so you want to be able to, sorry, I talk really fast sometimes. So, but whenever we talk about your pain levels, so there's also going to be a point where they say, at what level are you okay? So let's say 3 out of 10 is your pain level. If that's where your pain level is, and they'll know, okay, we're not gonna give you any more pain medication at that point. What we've already given you has been sufficient. But if your pain level is 5 or 6 out of 10, then at that point, then we know that it's not, your pain is not well managed, and we need to figure out a way how to best assist, whether it be pharmaceutical or even essential oils or music therapy or touch therapy, massage therapy, things like that. It's not just pharmaceutical. There are different ways to help with stress and pain. So the spiritual comfort is another goal of care. So let's just say you were to say there are religions that do not accept like blood byproducts, right? So you can say that. So whenever you go to a hospital and you say, look, it doesn't matter what it is, doesn't matter if it's going to save my life, you are not allowed to give me any blood products. Okay, so no, and there are parts of our communities that are like that, and you want to be able to communicate that with your providers. And so personalized care, right to be informed. It's very important to know exactly what you need, like how to get the resources that you want, that you need to be able to make informed decisions. So it hurts me so much when I have patients who come in and they don't know that they have a right to some of these services. And it wasn't like, for example, when it comes to hospice, you are allowed to have every 2 months, you're allowed to have a respite as a caregiver. So and actually that's covered by your insurance company, at least 5 days that where your patient, the patient themselves, that you say if they are an Alzheimer's patient and they are not able to care for themselves at all, they can't feed themselves, they can't clean themselves, they can't do their activities of daily living, and you're the caregiver and you have to do all of that for them. Being a caregiver is tiring. It is very taxing. And so, the insurance companies do know that, and they have put in place in a way to care for the caregivers as well, but they don't advertise that as much. They don't really tell you that, hey, you are allowed to have 5 days. We'll take your patient, your family member, and keep them in a location, in a nursing home or a inpatient unit, watch them for you for 5 days, and you can have a break. So, and that is free of charge under your insurance. So that's part of the support of the caregivers. And that, to me, when I have my patients, I go see them and find out exactly what's been going on for the caregivers, and they don't know that, and they've been on service with us for 6 or 7, 8 months. I'm like, man, you could have had 4, respites at that point, which you really do need. So coordination of care is also a big thing when you go to providers and say, hey, I want my daughter, my son, my cousin, whatever who it is, I need them to be part of the loop, or I need my cardiologist, my lung doctor, my kidney, I need you guys to talk to each other so the medications you're giving me are not interacting with each other. Because so many times I'll have a patient who's given high blood pressure medications to bring their blood pressure down. And then they're also given a medication called midodrine to bring their blood pressures up. So they're taking both of them at the same time. So that in itself, you have to be able to understand and talk to your family, your caregivers, your providers, in order to best make informed decisions for yourselves. Okay. All right, next one. Okay, so understanding the underserved population. So, of course, this is what we are here to do, right? We want to inform you, but we want everyone to understand when we say underserved population, what does that mean? It is people that don't have essentially access. They have limited access to essential services. So they're limited by their knowledge, limited by their finances, limited by geographical area. Those are the things that when we point out that is called their underserved population. And so we want you to understand when it's not there's different aspects. And that's why I kind of chose this picture to kind of just showcase the diversity in our underserved population. So, okay. And it even includes like our LGBTQ families, patients and all that, those that have like poverty or discrimination populations too. So it all encompasses that. So, yeah. All right. So moving on to the disparities that we have. So there are the financial barriers that we have that we are often the most popular types of, the most common one that people are always, and if you say what kind of disparities you know of, the first thing you can go up to is, economical, the financial barriers. And that's really is the lack of insurance. Some of them have high out-of-pocket costs, but in the underserved, sometimes it prevents them from being able to get the care they need. But most times when it comes to hospice and palliative care, it is covered by Medicare and Medicaid. And some of the insurance companies should cover them too. But essentially, I have a big caseload of patients, and probably about 99.4% of my population are Medicare and Medicaid patients. So, because it's usually towards the end of life, but it doesn't mean that I've had patients I've had an 8-year-old patient, I've had a 40-year-old patient. So, if you're not Medicare eligible, then your insurance companies, your regular insurance companies should be able to have those options for you as well. Okay. And so then the cultural language barriers. This is one of my favorite ones, right? Because I'm from Haiti, and we see that in my community all the time. Oh, we don't know, we don't understand what is hospice. We don't understand what that doctor's talking about. We don't understand, they don't understand my culture. They don't understand that, hey, you know what, whatever it is, if you need to wear a hijab, or if you need to have, you have to have it covered, your body covered, you don't let your skin show a certain way, or certain words, language, the medical jargons are hard to understand and hard to translate. And when it comes to medicine, when you go to Haitian Creole, talking in French, talking in Spanish. So not having the proper interpreters hinders that. It causes that disparity, which is, but you have to understand that as a patient, if you're going into a provider's office, you are entitled to get an interpreter. They are not allowed to have you sign documents that it's not your primary language and you don't understand it. They have, whether it is a system or a software, they have to have the option for you, given that especially Medicare patients. So if you don't have, and sometimes in some places, they're not even allowed to use your family members if your family member is not medically inclined to translate for you. So you need to be able to say, hey, I know my rights. I need to have somebody come in here and help me understand and translate for me. So knowing that helps you make a better informed decision. So we're talking about geographical barriers. So rural areas, it is crazy to think we are in the metroplex of Tampa, St. Pete area, but just 20 miles up the road, you are in the boondocks of Homosassa, of Dade City, Zephyr Hills, where there are food crisis, food deserts, and you have rural providers that are not accessible. Even if you don't even go there, you can even find it here in the communities you are, although they might be in the corner, but then oftentimes your patients can't come to them. So those are the type of disparities that we will see in the vast areas of Florida, which is right next, it's our next door neighbors at this point. So the lack of awareness and education. So oftentimes, we have our families who emigrate here and they didn't learn the language here and they didn't get educated here. And they don't know exactly where to find those resources or the education to be able to understand what is diabetes. Diabetes is that die disease. I'm gonna die because it says diabetes in it, but it really isn't. I've had people say this to me. Yeah, and then they're like, but no, it's about that. Your sugars. You have to be able to to understand what to do. Like I've even had my 7-year-old who's like, so there's different types of diabetes. I said, yes, there are, and and it's great that she's asking those questions, but unfortunately, our elder populations often don't. And they don't understand the differences. They don't understand what causes high blood pressure, what causes kidney disease. That oftentimes kidney disease is long years of uncontrolled blood pressure that is causing you to have your kidney failures, okay? So that kind of awareness and education helps make you have, again, informed decisions. In the systemic cultural structural barriers, it's more so about, their lower class versus their middle class and upper classes and stuff, and just not having that kind of access to their care, or the information they need. So, okay, and then we'll go on to the next one. Oh, actually, no, let me stay here. I'm sorry. Let me go back a second. I had some facts, like I forgot to point it out. So about African Americans are 30% less likely to use hospice care more than whites. Okay, so that's significant to me, that we're leaving that many people, that's not getting the access that should be getting them. And usually, you start wondering why, and a lot of these are playing factors as to why they're not getting that care. Okay, and then there's socioeconomical disparities. So individuals with lower income levels are 50% less likely to receive hospice care with lower income. So like half of them are not getting it. Okay. And we talked about the geographical barriers. So 60% of our rural residents have limited access to hospice care compared to urban residents who are living in here in our Tampa Bay, Pinellas area. So, and then there's also the gender disparities. So women are 10% more likely to use hospice care compared to men. And you start wondering, why is that so important? Sometimes it plays into the cultural aspect of it. Oh, we're big, strong, and we can do this as the men, sometimes can have that perspective, but know that, pain is pain. It's the comfort is important as well for men. So it's okay to have that talk with your provider and your family members to have that opportunity for you. And then, Hispanic Americans have significantly lower utilization rates of palliative care services compared to non-Hispanic whites. So, so those are some things that I wanted to point out so we can make sure that it stays in our forefront that we have our, Black and brown sisters and brothers who need to be made aware of these services so that they can be able to have access, because our Caucasian counterparts are bypassing us and getting those access that we are entitled to from being here in this country. So, okay, all right. Okay, the importance of culturally competent care. So what is cultural competent care? So it's just really about, it involves providing healthcare services that respect and respond to their cultural beliefs. So we talked about the window, we talked about our, you're not being, not accepting blood byproducts, or having a priest, chaplain, whoever to come out and be with you. Depending on your culture, some people believe in different things, so they want certain things to be available to them. So knowing that there is, especially in this group patient population or this population of people that we're talking about, it's important to know those type of to be culturally competent when we are addressing our family and friends. So what are examples of competent care? There's language and communication, again, being able to translate appropriately to better understand, to speak in a way that it's not medical jargon and in layman's terms in order for us to better understand. Like, they don't need to understand, okay, your INR is this. How is that? What does that mean to them? It just means whenever we talk about an INR, we're talking about the blood, like if it's thin. So they, if you're talking to somebody that's not in the medical field, they don't understand that. So you want to be able to have your healthcare providers explain those things to you. So family involvement, how much of it you have, when it comes to your culture, you have people where the husband is really the one that makes decisions, even despite that the situation's happening to them. But the husband really is the one who talks and makes decisions for them. So when it comes to, there's different cultures that interact in that way. So understanding of illness perception. So whenever you are sick, you don't, and I've heard this many times, "Oh, say Jabla, or it's the devil that's coming for you." But it's not, like, it is certain things that I believe in, but others may believe. And so you have to kind of understand those things to better maneuver the cultural, the medical aspect landscape that we're in. And you can have, there's so much training and education out there. Always find reputable ones. Google is not always, because if you go and tell Google, I have a fever 100.0 and a cough, and my big toe hurts, it's gonna tell you gonna die. Don't believe Google. So you have to find a reputable place to get your information. And just because one person, my auntie from my other mother, from my other cousin, took one medication and it did this to them, does not mean it's gonna be the same for you. So it's our medical system there are flaws in there, but use that information wisely. We have gone to school and been able to educate our patients the way that we've been best taught how to do it, but you want to definitely find the best sources to help make those decisions for you. So in advanced care planning, it involves financial planning, wealth planning, whatever it is, like health planning, making sure you have, I don't know if Tasha's made one of these before, but I think you might have doing like the wills and so advanced directives, your health proxy, because one situation that I have is I have a patient and his wife. They have been together for 15 some years. This is not their first marriage, but they never got married. And they thought, oh, I don't have to get married because of common law wives and husbands. And I spoke to an attorney about it, and that it's no longer, as effective as it used to be. And so then that wife now, who's been taking care of the husband who's had Alzheimer's for the last 7-8 years, now and he's no longer able to make decisions for himself, now has no rights, because now his kids are coming in and writing off everything, selling off everything, and now she's gonna be left with basically nothing. So that's also part of your advanced care planning. So you want to make sure that those things are addressed. We don't bring these information just for it to go over our heads. We really want to educate our population, because these are things that our Caucasian counterparts are already doing. They've been doing. And it's so sad when I come into contact with my people and they don't have their stuff in order. So, and you go to probate court and you lose a lot of your privileges. So, okay. So that wraps up the cultural competence part.
Hello. Watch What's going on? Hello.
Hello.
Watch
Oh, you didn't hear anything I said? Okay. All right, so what I was saying, so the next part of this presentation is about the myths about hospice and palliative care. Because I think the best way for me, the way that I love to educate and to provide information is by having really more of a dialogue, right? And so, or at least dispelling some of the myths that we have about hospice. So hospice care is only for people who are actively dying. Unfortunately, it's not. It's one of the biggest myths out there. Hospice care is for individuals with a life expectancy of 6 months or less, but it focuses on improving quality of life through pain management, symptom control, and emotional support. So, and all of that pretty much says, like, yes, we initially think you initially get you on service, because if the disease process was to continue and its natural progression, that it would be that your life expectancy would be 6 months or less. Would you believe me if I told you that I've had many patients that have been on service with me for more than 2 years? And at that point, I've had to discharge them. And I don't say discharge, I like to call them graduating off of service. We are graduating you, officer, because you are doing so amazingly well. But essentially what happened is you have patients who come on and they were doing, if this is say they were there for heart failure, they come on for heart failure, they were on oxygen, so much oxygen, their legs were getting so swollen, they were short of breath all the time, and they were exerting themselves so much. And so then there was really nothing else that they could do. But they were going back and forth to different doctors' appointments, to their heart doctor, to their primary care doctors, to kidney doctors. And then so that in itself is exerting them. But then now they come on service with us, and now we come to them. And then they don't have to go back and forth all the time. And then sometimes they have a lot of pills and medications. And so we reduce their pills that cause them to have pill burden. And then they start feeling better. Like they don't have to go so far anymore. Some of the medications that were supposed to help were no longer helping. And so their quality of life is better. And so they end up living longer. And there was a documentary that I saw, it was Blue Zones on Netflix. And so there was this gentleman who they were told, the one that stuck out the most to me, the documentary that stuck out the most was that this gentleman was told that he had 6 months or less to live, he had cancer. And then he went back home, I think it was to Italy or Greece or something. 8 years or so later, he was still alive. They had told him, hey, his plan was to go back home and pass away. And y'all, it's not that, I'm not saying that, the system here or the United States are trying to kill you. It's not. It's just that you have to be. Some people may defer. But they do. We are in a culture where profits are a big thing. And there's just different ways of living, and there are ways that they see it should be, and sometimes they don't really pay attention to the side effects that really happen to you. So yeah, so it's one of the myths. So myth number 2. Oh yeah, sure. Yeah.
Wait, there's 2 questions. Let's start with one. Does hospice care has to be referred by a physician to confirm that the patient has 6 months or less of life?
Oh, that is such a great question. No, anyone, actually, your neighbor can refer you for hospice. It can be anyone. It doesn't have to be your provider, your physician. You can request it on yourself if you wanted to. And then at that point, then you have a team of physicians and nurses that do come and assess you. We'll get all your documents, your medical documents, and they'll review them, and then we'll determine if you are appropriate to come on service. So, yeah.
And here's a segue question to it.
Yeah.
If you know that.
How much percentage-wise
Mhm.
does insurance typically pay for hospice care?
So generally it should be, how I would say, my patients usually do not have co-pays. And that's not part of my department. But I will say, like, from what I know, is that we have a list of things that are formulary and things that are covered. And then we'll tell you here, this is what you can do. Now, if you want to do, like, for example, certain medications, like your thyroid medication, unfortunately, will not be a covered medication. But if you want to do that, you stay on it, then you'd pay for it out of pocket. So.
And I guess if you're gonna end up on Medicare, then it's usually like a blanket coverage, so it's easier to know what's covered, what's not. But when you have private insurance, it is best to go directly to the private insurance because their business, each one of them have
Different. Exactly. Yep, they are very different. So. Yeah. All right, myth number 2. Yeah. All right, palliative care is the same as hospice care. So no, it's not. They are very much both about quality, improving quality care, quality of life. But palliative care is can be provided at any stage of a serious illness. So it can be at the very beginning of your diagnosis of heart failure or kidney disease. And versus where hospice is specifically for individuals that are near the end of life. So generally I'll have patients who come on service who are, in our professional opinion, are near the end of life, but they're not quite ready to come to terms with that. They don't want to stop aggressive treatment. And so then I would refer them to our palliative care services instead, because the hospice model essentially is, I'm tired of going back and forth to these doctors. I'm tired of blood draws or getting poked. I'm tired of imaging, testing, and all that. So the hospice model is less is more. Whereas palliative care is, we still want to do the blood work. We still want to go to all the different doctor's appointments. We still want to get imaging done. And so in that sense, yeah, we still, like, we're going to do this, we're going to keep doing it. So that's where the differences are when it comes to hospice and palliative care. So is that clear as mud? You guys understand that? Good. All right. Ready for number 3. All right, hospice care means giving up hope. That is one of my saddest ones for me whenever people do think that, because it really isn't about hope. It's about doing it your way. So I had a patient at the beginning of my career she had colon cancer. She was kind of like an auntie. Like, she just was always happy, go lucky, and just happy to see you, and despite everything she was going through. And one of the biggest things, I ended up going to her funeral. And as she showed up with her slide of her pictures and stuff, that was the song she played, I Did It My Way. Because she essentially did not let, she knows she was sick, but she didn't want to have to be back and forth and having tubes and being just not presentable for her family in a way that she felt it was respectful to her. This lady was going on trips everywhere she can, anytime she can. And I would be having to be like, hey, ma'am, I need to come see you. She's like, oh, but I'm going to Mexico tomorrow. So, but I gotta see. She's like, well, can you come down? And I was like, okay, fine. So, so we'd have to be able to catch her. But it's not about giving up hope. It's just, there are certain things our modern medicine can do. There is a limit to it until it actually, because like some of your cancer medications, although they are good to kill those bad tumors, but it also does take a part of you out too, the good parts. Just like some bacteria, like some antibiotics. The antibiotics are there to take away the bad bacteria, but then it also takes out some of the good bacteria, because you are supposed to have good bacteria in your gut in different areas of your body. So you need that. So it's just some people, you just decide what's better, you know? You still, you may feel better for, you may feel good for a little bit, but do you have the side effects? Or just really managing your symptoms and remaining comfortable could be a different perspective, so.
Okay,
All right,
myth number 4.
so hospice care is only for cancer patients. So, and like I've said before, it's not, so it is and actually, if I look at my patient population, my patient load right now, I will probably say maybe about 25% of my patients are cancer patients. Yeah, they're not the most common. And some of my most common ones is Alzheimer's. There are some like the heart diseases, the lung diseases, like the COPD, chronic obstructive pulmonary disease. There are like the heart failures, like I mentioned, the diabetes. Sometimes when you are so significantly advanced, because it then also can cause your kidney damage. There are some like liver cirrhosis patients who end up, it can be caused by alcohol or non-alcohol. So it's just different aspects of that disease. So, but my most common one is my Alzheimer's and dementia patients, which is the hardest one, guys. It is tough in a sense because it varies for so many different people. And you can be in an Alzheimer's dementia state and for various lengths of time. So you can go from, not remembering your name in 1 year, and then next year, you can't feed yourself. Or it can be the same, like you can just not remember your name for a whole year. It's just that there's no concrete way of like how it progresses for everyone. So it's difficult to, it can be difficult to manage. And those are oftentimes my patients that do graduate off the service because you have patients, like one of my most debilitated patients does not talk, barely opens his eyes. He is contracted, which means like he is like this all the time, like his legs is drawn up, his hands are drawn up, and he's so stiff. He doesn't feed himself. He doesn't toilet himself. So everything is done for him. And you would think, hey, this is a pretty debilitated patient. And so he needs the care, he needs to remain on service. But then we end up having to let him go. Let him off of service because he has such good care. His caregivers are always making sure he doesn't have wounds. If there is like a sniffle or something that they give him, that they pay attention to that. It takes them an hour and a half to 2 hours to feed a small baby-sized meal, like a toddler-sized meal for him, but they're so patient. They're so patient with him. So, but yeah, so that's, so the Alzheimer's is one of my hardest ones. All right, myth number 5. Hospice care is expensive and not covered by insurance. So yeah, we talked about that. It is covered by Medicare, Medicaid, and most private insurance plans with a little to no out of pocket for patients and families. So that is something to always remember, and that not all hospice companies are the same. So there are non-profit hospice companies and there are some for-profit companies. And the company that I work for is non-profit, and so they would take patients who essentially don't have the funds to pay to. So because they get grants in order to do that, to be able to take patients who do not have the means. So always, each county, it is regulated. You can't just have 5 million hospice companies in one county like there are home health companies, because they are regulated by our states. So you have to ask it's a letter of necessity, I think it is, that you have to ask the county, like you have to ask for permission to open up a hospice company. So always look to see in your county which companies. Usually, most counties around here have 2 or 3, at least probably more than that. So shop around before you choose one. Okay. But yeah, number 6. Hospice care type of morphine, because that is our big cultural topic, it hastens death. Hospice care neither hastens or postpones death. It focuses on providing comfort and support to patients and families during the end of life. So, that is I remember when I was growing up, it was like, oh, give them morphine, they're gonna pass away. It's a misconception in our culture, but unfortunately, it's not. It is an opioid. However, when you look at the different types of opioids that are available for pain management, have you heard of Percocet, oxycodone, that you often sometimes are given after your dental procedures? Oxycodone is actually more potent than morphine. Yeah, more potent, okay? So morphine is the same potency as a Norco, like it's a hydrocodone. It's a milder form of opioid. They all are opioids, but morphine does not hasten it. It does suppress your drive, but if essentially the drive to breathe, but essentially at the end of life when you are sometimes your heart rate goes faster. It's harder to breathe. We need it to be calm. We need to calm you down because your heart rate is so high, your blood pressure is so high. Sometimes the only thing we can do is to bring it down to make it more comfortable. That's not comfortable. We would use morphine to do that, but we use it sparingly, and we listen to make sure you feel comfortable to do so. Okay, to use it, but it's a big misconception that oftentimes I have to help dispel when it comes to my patients. So it does not hasten your death because it's going to happen and life is going to happen. Your decision is how it's going to happen. How comfortable will you be in the process? So, okay, number 7. Hospice care is only available in the facilities or hospital. Like I mentioned before, you don't have to just be in the hospital or in a facility or nursing home. You can do it at home. Most hospice care is done in the home, at least in the company that I work with. And so we go into your home and we make sure that you're comfortable and we provide you the resources. You get all of that. If you need a bedside table, a bedside commode, or a hospital bed, we provide all that to you. And so you can do it at home in Weston Chapel, at home by the beach, whatever it is. And so it's up to you. So, all right, last myth. Hospice care is only for the elderly patients. Like I mentioned, I've had a patient who was 8 years old before. I've had a 40-some-year-old patient. Unfortunately, given the fact that in our society where there are so many pollution, the food that we eat is not so good for you, and not always great, or there's so many different aspects of things that we're introducing to our body is actually really causing us harm. So oftentimes we're seeing our patients getting younger, pass away. So so it's not so anybody along the lifespan will can have a terminal illness. So it's not just for elder folks. But, yeah, and that's it. Any questions? Huh? I think I was done. I think that's my last. That's my last slide. I think so. Oh, my key points.
Thank you, Laura.
Sorry. Yeah. So my key points is, it's not hospice is technically for patients with 6 months or less, but you will graduate off of service if they don't see you appropriate for it. This palliative care can be started at any point of your illnesses, just to make sure that your pain is well managed, that you're more comfortable. We work cohesively as a team when it comes to palliative care to make sure that all of your goals of care are addressed and work seamlessly together so that we can be like, hey, remember, she doesn't want this. So, and find the training, the resources in order to be able to help to make informed decisions for yourselves. So everyone deserves quality end of life care. So, it's not just to anybody else, but, or just to your neighbor next door, it's for everyone. So by being more knowledgeable, it helps. So.
We do have a question.
Okay.
If the hospital doesn't have someone that speaks your language, can you call someone while the doctor is in the room?
Yeah, so most hospitals, actually almost all hospitals in this area will have interpreter services. So now if you move onto like areas where, more into the rural areas, they might have a difficult time having somebody on site that's an interpreter. But nowadays you have your phones and your softwares, those providers should be able to have those softwares and have access to those things for you. And if they don't have it there and don't have it, then you need to just kind of demand it, unfortunately, because it is your right to have so.